Okay, let's just pause for a second. Imagine you're an injured worker, hurt on the job. Maybe it's your back, maybe a shoulder. You're in pain, feeling pretty vulnerable, honestly, and you're putting your faith in your doctor, right? The expert. You're counting on them to know what to do to guide you through recovery, through this whole complicated workers' comp system. There's a huge amount of trust involved. But what if the trust gets broken? Badly broken. That's what we're diving into today. We've got our hands on a really specific and frankly quite revealing document. It's an official letter from the Workers' Compensation Board dated April 2nd, 2025. And it's not just some memo, it's a formal denial. They're denying a doctor's application to renew his authorization to treat injured workers, specifically a Dr. Joseph Weinstein. So our mission today is to really unpack this. We're going to dig into the details behind why the board made this decision, looking at specific patient cases, patterns of behavior they found. We want to see what this tells us about the standards of care we should expect, and how the workers' comp system actually oversees things. It's a rare chance to see how the system polices itself, you know?
It really is.
Yeah.
And before we jump into the specifics of the letter, it's helpful to understand the setup. Doctors can't just decide to treat workers' comp patients. They need to get specific authorization from the Workers' Compensation Board. And getting that authorization, well, it comes with strings attached. They have to follow the workers' compensation law, the board's rules, and critically, these things called medical treatment guidelines, or MTGs.
MTGs, sort of the rule book for treatment.
Exactly. Think of it as the evidence-based playbook for care within this specific system. You have to stick to it, or have a very good, well-documented reason not to.
Okay, got it. So let's unpack this denial letter. The board starts with an executive summary, kind of the headlines, right? What were the big issues they flagged right off the bat?
Yeah, they didn't mince words. They laid out 6 main areas, broad categories of non-compliant behavior. First, exposing patients to unnecessary risks from invasive procedures. That's a big one.
Yeah.
Second, just not keeping good records. A lack of adequate, credible documentation. Failing basic medical record-keeping standards. Third, linked to that, often lacking clear medical justification or clinical reasons for the procedures they were doing.
So doing things without a solid why.
Pretty much. Fourth, submitting prior authorization requests, PARs, for treatments that are outside the guidelines, these variants PARs,
Yeah.
without properly backing them up. Fifth, doing procedures way more often or in greater quantities than recommended, again, without justification. And sixth, just straight up billing irregularities, problems with how they were billing for services.
6 major areas.
Yeah.
That's quite a list. It doesn't sound like minor slip-ups.
No, the board presented it as a pattern.
Wow.
Deeply systemic problems, not just isolated incidents.
Okay, and here's where it gets really quantifiable, right? The board didn't just look at individual cases. They compared Dr. Weinstein's stats to the industry average, especially for those PARs.
Right, those prior authorization requests. Specifically, the variants PARs, the ones asking for treatment outside the normal guidelines. And this statistic, it's pretty stark. In 2024, Dr. Weinstein's approval rate for these variants PARs, when they went up for review by the board's medical director's office, was only about 27%.
27%. Okay, what's typical?
Well, the industry-wide average approval rate for those same kinds of reviews in the same period was 54%.
Wow, so less than half the average approval rate.
Exactly. It means his proposed treatments, the ones deviating from the standard guidelines, were found to be clinically lacking or unsupported more than twice as often as the average doctor in the system.
So for you, the listener, what does a gap like that really signal? It's more than just numbers, isn't it? What's the implication for patient care and maybe even the system's finances?
It's a huge red flag. A rate that low strongly suggests that the treatments being proposed weren't consistently meeting the standard of medical necessity or weren't backed by solid evidence. For patients, it could mean being pushed towards procedures that aren't really justified, bringing unnecessary risks, maybe longer recovery times, potential complications. And financially, it suggests a pattern of asking the system to pay for treatments that are often deemed unsupportable. That drives up costs without necessarily improving patient outcomes. It really undermines both patient safety and the system's efficiency.
Right. It hits on both levels. Okay, so that 27% gives us the big picture alarm bell. But the board, they went deeper, right, into specific patient files to see how these issues actually played out. Let's start with the first case they detailed. Patient G2792493, a young patient apparently. Tell us about them and what happened right from the start.
Yeah, this claimant was born in 1995, so not even 28 years old at the time. And on their very first visit with Dr. Weinstein, back in December 2023, the recommendation was immediately for a major surgery, an L4-5 decompression and lumbar disc fusion.
First visit. For someone under 28, wow. What was the justification given?
Well, the documentation claimed the patient had failed all non-operative treatments like PT and injections. But as the board found, the records didn't really back that up strongly.
And how did this major surgery even get approved? You mentioned something about a level 1 issue.
Yes, this is really important to understand how the system works, or sometimes how it doesn't work as intended. The PAR for this fusion surgery was actually granted by the insurance payer, but only at level 1 review.
Level 1 meaning?
Level 1 is typically done by a claims examiner, think administrative checks, paperwork review, not usually a doctor or a clinical specialist reviewing the medical necessity in detail. The board was very direct here. They said it was eminently likely that if this request had gone to a level 2 review, which is a medical professional, or if it had been escalated to the board's own medical director's office, it would have been denied.
So it slips through because a medical expert didn't properly review it at the payer level.
Essentially, yes. And the reasons it likely would have been denied by a doctor were numerous. The MRI and CT scans submitted with the request. The board called them unremarkable at the levels targeted for fusion. There was only a shallow herniation, no significant spinal narrowing, no instability, no signs of nerve compression, causing leg symptoms, what they call neurogenic claudication. These are key things you'd look for.
Okay.
Plus, the records only showed 2 prior epidural steroid injections. One seemed to help a bit, the other lacked clear documentation on the outcome. And there wasn't much evidence of a solid try at conservative care, like physical therapy.
And wasn't there some question about where the pain was even coming from?
Right. Given the original injury was to the lower leg, the board felt the doctor hadn't adequately ruled out the leg as the primary source of pain versus the spine. You need to be sure before you fuse someone's back.
Absolutely. So for this young patient, what were the consequences of getting the surgery approved under these circumstances with all these documentation gaps?
Well, the most immediate consequence is that this young person was exposed to really significant surgical risks. Risks the doctor himself listed on the consent form. By the way, infection, nerve damage, paralysis, blood clots, CSF leaks, even loss of limb or life. Major risks for a procedure that seems questionable from the start.
And the timing was an issue too, wasn't it?
Yes. The surgery didn't happen until 9 months later, September 2024, and the board found little or no documentation of interim progress or deterioration. Basically, no notes showing if the patient got better, worse, or stayed the same over those 9 months, which is critical. Their condition could have totally changed. The board called this unacceptable clinical practice.
Unacceptable. And there was another issue with equipment after the surgery.
Yeah, a request for an electrical bone growth stimulator. First, he submitted the PAR under the wrong category DME instead of special services. But even setting that aside, the board said it would have been denied anyway. There was no clinical evidence the patient was at high risk for the bones not fusing, which is the main reason you'd use one of those devices. It just added to the picture of questionable necessity and not following protocol.
Man, that one case alone is troubling, if you had to pick one thing from that case.
For me, it's the potential harm to such a young patient. An irreversible major surgery pushed through seemingly without adequate justification based on shaky documentation, exposing them to serious risks. It just screams poor clinical judgment and disregard for established guidelines.
Okay, let's move to the next example the board cited. Case G3109378. This involved a construction worker, 33 years old initially, and here the board talked about a predetermined treatment focused on multiple surgeries. What did they mean by that?
This case really illustrates a pattern. It starts with inconsistent recommendations, at one point suggesting PT, but then quickly moving to propose a cervical fusion, C6-7, for axial pain.
Axial pain. That's just neck pain, not radiating down the arm.
Generally, yes. And fusion isn't typically the first line or even second line treatment for just axial neck pain according to the guidelines. There were also contradictions in his own notes about whether prior injections had actually helped the patient.
And the record keeping again.
A problem again, yes. Lots of copy forward notes just pasting old information into new entries without updates, missing details like dates and facilities for MRIs, vague descriptions of prior treatments. And like the previous case, the PAR for this cervical fusion, although it was a hefty 57 pages, was granted at level 1 by the payer. But the board's review found it still didn't have enough solid justification. Again, likely would have been denied by a medical reviewer.
57 pages, but still not enough substance.
Apparently not the right substance. And then there was conflicting advice, recommending more injections while also scheduling surgery, ASAP.
Wait, recommending injections and scheduling surgery at the same time?
Exactly.
Yeah.
Which suggests conservative options weren't really being exhausted. This is what led the board to say it looked like a predetermined treatment focused on multiple surgeries.
And it didn't stop with the neck fusion.
No. After that surgery, the doctor then recommended another major fusion, this time lumbar, L5-S1, for the patient who was now 36. And the board specifically noted something striking. There was no documented discussion in the office visit notes about how having multiple spinal fusions might impact this person's ability to go back to construction work, or the high chance they might need even more surgeries down the line.
That seems like a critical conversation to have with a patient, especially a manual laborer.
Absolutely crucial. And for this second proposed fusion, the supporting documents were again found lacking. Relied on a 2-year-old X-ray, apparently misrepresented or misread MRI findings. And here's that pattern again. Denials for things like bone growth stimulators and PT requests. The doctor never escalated them to the medical director's office for review, even though he supposedly thought the patient needed them.
So he asks for things, gets denied, and just lets it go.
Lets it go, doesn't use the appeal process available. The board called this curious and problematic. It really makes you wonder as you listen to this, if a doctor truly believes a patient needs something, why wouldn't they fight the denial through the proper medical review channels? It raises questions about priorities. Was the focus truly on the patient's comprehensive long-term well-being?
Yeah, that lack of follow-through on the denials is odd. Okay, so beyond the clinical judgment, the board also hit hard on administrative stuff, billing, paperwork, process. Case G2710682 seems to highlight this side of things.
It does. This case brought up more documentation issues, like not seeming aware of or discussing prior MRI findings with the patient. But it really showcased billing problems. Things like submitting bills for visits, but not actually sending the required medical reports to the board to justify them.
Okay.
Resubmitting the exact same bills for services that had already been denied as duplicates or excessive. Just sending them again.
Trying again, hoping it slips through.
Perhaps. And also failing to use the proper channel arbitration when the payer objected to the value of a bill within the allowed time frame. Instead of arbitrating, he just didn't. The board said this causes needless friction and delays in the system.
And excessive billing was mentioned, too.
Definitely. A concrete example. Billing $1,300 for an 80-minute permanency evaluation report. The official medical fee schedule specifies $407 for that type of report.
So more than 3 times the allowed amount.
Correct. Over triple. And they also flagged billing for X-rays, deemed unnecessary because another one had been done just 4 months earlier. And yet again, we see PARs for physical therapy being submitted, getting denied for lack of objective improvement or not meeting guidelines, and then never escalated to MDO review. The pattern continues.
So when you add up all these administrative and billing issues, what does it mean for the workers' comp system as a whole? It's not just about one doctor's revenue.
Not at all. It clogs the system.
Yeah.
It wastes resources, administrative time, reviewer time, payer time. Inappropriate billing drives up costs unnecessarily. Failing to follow dispute processes creates backlogs and frustration. It fundamentally undermines the efficiency and integrity of the entire system, potentially slowing down care and resolution for all injured workers because resources are tied up dealing with these kinds of issues. It shows a provider not playing by the established rules, which impacts everyone.
Okay, one last case example they highlighted, G3103819. This one seems to really hammer home the pattern of asking for treatments, specifically PT, that just weren't supported.
Exactly. It's almost a case study in persistence without justification. The patient comes in, initial visit, some pain, but maybe not super specific. Doctor recommends MRIs and PT right away. Then, multiple variance PRs for physical therapy, neck and back, are submitted over time. And they are consistently denied. Denied by the payer at level 1, denied at level 2 review.
And the reasons for denial were?
Consistent reasons. Lack of documentation showing prior PT actually helped. No clear medical reason given for deviating from the treatment guidelines. And sometimes findings from independent medical exams directly contradicted the need for more therapy, like noting the neck pain had resolved or that back therapy wasn't recommended at that time. And the kicker. Despite all these consistent denials based on clinical reasons, none of them were ever escalated by Dr. Weinstein to the medical director's office for a higher-level medical review.
So you really have to ask, why keep submitting requests you know are unsupported, that have already been denied with clear reasons, and then never use the available process to challenge those denials if you genuinely believe they're wrong?
It's a critical question. It points towards perhaps a disconnect from the clinical reality, or maybe not understanding the system's rules, or maybe just not tracking or responding appropriately to the denials. Whatever the reason, it's not good medical practice and wastes everyone's time.
We've gone through these specific cases now, the young patient, the construction worker, the billing issues, the repeated PT requests. If we kind of zoom back out and connect these dots, what's the big picture the board painted? What's the collective takeaway?
Well, taken together, the board saw a clear, consistent, and frankly pervasive pattern of misconduct. It wasn't just one thing. It was repeated violations of the medical treatment guidelines, the workers' compensation law itself, and the board's regulations. A consistent failure in basic record keeping, not enough credible medical documentation. Regularly failing to provide solid clinical justification for deviating from the standard treatment guidelines. Performing invasive, risky surgeries without clearly exhausting safer conservative options first. This pattern of submitting PRs for things already denied, without new evidence, and crucially, that consistent failure to escalate denials to MDO review. And finally, not following billing rules and charging excessively. And legally, what does that all add up to? The board stated clearly that this conduct constituted grounds to deny his authorization renewal under specific sections of the workers' compensation law, Section 13D2A and D, for those keeping score. They also stated it amounts to professional misconduct under New York's education law, which governs medical licenses, specifically citing sections related to negligence, incompetence, and failing to maintain accurate records.
And the board has the power to make this call.
Yes, they noted their authority in this area has been tested and upheld by the state's appellate courts.
Okay, so the authorization is denied. What happens now for Dr. Weinstein, and more importantly, for the patients currently under his care?
Right, patient care is paramount. Dr. Weinstein was directed to give the board a list of all his current workers' compensation patients and a plan for transitioning their care to other board-authorized providers. This had to be done within 10 business days. He's immediately barred from performing any new workers' comp surgeries or taking on any new workers' comp patients.
But what about people he just operated on or who have appointments scheduled?
Good question. The board granted a 30-day grace period. This allows him time to manage immediate post-operative care for patients he recently operated on and helps facilitate the orderly transfer of other patients to new doctors. It's designed to prevent patients from being abruptly left without care during the transition.
That makes sense. So this deep dive into just one denial letter, it's been incredibly illuminating about the inner workings, hasn't it?
It really has.
We've seen the specific reasons, clinical judgment, documentation, billing, following the rules that led to this decision.
And it underscores just how vital the oversight role of bodies like the Workers' Compensation Board is. It's not just bureaucracy. Their job is to protect injured workers, to make sure the care they get is appropriate, justified by evidence, and that the system isn't being misused financially through unnecessary procedures or improper billing. Those layers of review, like the MDO review that Dr. Weinstein kept skipping, they're there for a reason. They're meant to catch these kinds of problems.
So here's something for you, the listener, to think about. When patterns like this emerge and are addressed, what does that do for overall trust in the system? And maybe more broadly, what does this whole situation tell us about how absolutely critical rigorous documentation and ethical practice are, not just in workers' comp, but everywhere in medicine? It's a stark reminder that accountability really is fundamental to good healthcare.